Good morning, everyone. Thank you for this opportunity to present uh, this work today. Um, can you see my screen?
Yeah.
Okay. So today I'm going to present to you my RIC project. So we are working on developing pharmacokinetic and pharmacodynamic modeling for anti-TB drug. So my name is Felipe Ridolfi. I'm one of the RIC fellows, and I'm also a postdoctoral research fellow at Vanderbilt University Medical Center in Nashville. So after the end of this presentation, I would greatly appreciate your feedback on the comprehension and clarity on this presentation on this work. So to start, I'm going to present the study that we've been developing, and we just submitted an abstract to the Union Conference, which is under review, and the decision will be in late July. And it is entitled Population Pharmacokinetic of Isoniazid in TB Patients, accounting for age, sex, weight, diabetes, and HIV. These are the authorship list. I highlighted here in bold the group that we've been working intensively on developing PK and PD skills in Vanderbilt. So it's me, Jordan, Dr. Selling, and Gustavo. To start, we demonstrated that individuals with tuberculosis and poorly controlled diabetes had a lower risk of adverse drug reaction. This was an interesting finding of a previous published work from my PhD thesis, and uh, we believe that these may be too low drug concentrations. As you can see here, this is a coefficient plot where we evaluated the baseline factors associated with adverse drug reaction during TB treatment. And as the glycated hemoglobin increases, the risk of adverse drug reaction decreases. To further investigate this, we decided to develop a compartmental population pharmacokinetics usually called POPPK model for isoniazid concentration with report Brazil data. We decided to start with isoniazid because the data on isoniazid were better edited already. So we considered from Report Brazil, culture confirmed drug susceptible pulmonary standard TB treatment participants, and we used the samples from month one. We have drug levels on isoniazid, rifampin, desacetyl-rifampin, ethambutol, and briosonamide. That the focus now will be on isoniazid. We quantified the drug levels through liquid chromatography spectrometry, and the samples below the quantification levels were excluded for this analysis. We're going to consider them for future analysis, but to start in a simple approach, we decided to exclude these samples below the quantification. We considered age, sex, body mass index, diabetes, and HIV status at baseline as covariates influencing the drug levels. We decided to start it with a simple approach using an one compartment PKPD model, which has three main parameters, which is the absorption rate constant, clearance, and volume of distribution. Important to highlight here, the clearance is the drug clearance, is not the random function of it. We used random effect to evaluate the inter-individual variability and the time since last dose of anti-TB drug was self-reported and recorded in hours. For the model parameter estimation, we use a software called Monolix, and for the simulations in which we use the model created to simulate different scenarios for the drug levels, we use it Simulx. At month one in Report Brazil, we had 333 participants, which contributed with one sample each one. In the end, we had 332 samples available that were collected within 8 hours since last dose. Of course, we had other samples out outside of this time frame, more than 8 hours. But for this analysis, we decided to consider only the samples collected within 8 hours since last dose. The final POP-PK model with best estimate had a constant of absorption of 0.59, a clearance of 6.12 liters per hour, and the volume of distribution of 6.2 liters. There was a considerable inter-individual variability with omega values for a constant of absorption of 0.33, with a coefficient of variation of 55%, a volume distribution of 2.85, varying 51%, and the clearance 1.3, with a coefficient of variation of 22%. These percentages are important because it estimates the variation among the participants for each parameter. So the lower, the better. And the final model included age, sex, weight, HIV status, but not diabetes. So participants with HIV had a lower absorption rate constant compared to HIV negative individuals. I'm sorry for the background noise. Females had a lower volume distribution compared to males. And as age increases, the volume distribution decreases. And as weight increased, there was an increased volume of distribution. Here in the figure 1, I show you the model performance, showing the observation versus individual predictions for NIH concentrations. So as you can see, as the concentration increases here, the prediction is not that good. In figure 2, I show you simulated prediction concentration of isoniazid stratified by HIV status. So as you can see, HIV negative participants had a higher concentration between 1 and 3 hours compared to HIV negative or persons, with persons with HIV. Here, the simulated predicted concentration stratified by sex, showing a higher concentration among females compared to males. According to the weight, so participants with lower rate, with a cutoff point of 50 kilos, had a lower drug concentration after 2 hours. And considering age, I stratify in 3 age ranges. So young participants had a lower drug concentration compared to older participants. The conclusions, so this POP-PK model captured the variability of isoniazid absorption, distribution, and clearance among participants in patients with pulmonary TB in Brazil. And age, sex, weight, and HIV status influenced the isoniazid concentration, but diabetes did not. We were expecting that diabetes would influence any of the POP-PK parameters, but for isoniazid, it did not influence any of them. It's important to highlight that different variables influence different PK parameters. So you saw that HIV influenced the constant of absorption, and female sex influenced the volume distribution, and age and weight as well. So as future perspectives and ongoing work, we are working on developing POP-PKs for other anti-TB drugs, and we are expecting to find any influence of diabetes in any of the POP-PK parameters for the other drugs. We're going to evaluate more complex PK models, considering 2 compartments, which includes more parameters. I will start writing the manuscript soon, and the idea is to include in the manuscript the models for all 4 drugs. And we also have data on antiretroviral drug levels, so we may look at POP-PK models for antiretrovirals among participants with TB and HIV. I would like to thank you, the participants, and also acknowledge Lucy, Her, Lauren, Cody, Dr. Bollinger, Mary, Argita, Daphne, Dr. Karen, and Dr. Golo, the RIC Fellows, and all the Report Brazil and RIC staff. Thank you very much.